Good day everyone, good day Doc Nika. My Qatar and UAE team will going to present all about gout, rheumatoid arthritis, osteoarthritis, its management and medications. But first, let me introduce to you my team members who are Irish Christine Eugenia, April Marie de los Reyes, Carolina Obaldo, Jennifer Gashon, and yours truly, Chloe Leotero. To begin with our presentation, I will give the floor to Miss Irish to discuss all about gout.
Good day, everyone. I am Irish from the Qatar UAE group. Today we'll be discussing some of the disorders of the musculoskeletal functions and the drugs used to treat them. So to begin with gout, gouty arthritis, or often referred simply as gout, is an inflammatory disease that happens when levels of uric acid in the body becomes too high. It is when urate crystals deposits in the joint, causing pain, redness, and swelling. And when this happens, it is called a gouty attack. So gout most commonly affects the first metatarsal joint or base of the big toe, and this condition is called podagra. Gout can affect other joints including the knees, ankles, feet, hand, wrist, and elbows. It may affect kidney tubule as well. Who gets gout? Many people can develop gout. It usually develops in middle age, and men are more likely to develop gout compared to women who do not usually experience it until after menopause. How does gout develop? The underlying cause of gout is hyperuricemia or too much uric acid in the blood, which results in the formation of sharp, needle-like crystals in areas with slow blood flow like joints and kidney tubules. To understand better where does uric acid comes from, let's take a look at the diagram of the purine metabolism. Some of the uric acid comes from the diet, while most of it comes from the breakdown of purines. Purines such as adenine and guanine are nitrogenous bases used in nucleotides to build RNA and DNA. So when a cell dies, these purines must be disposed of. The body does this by converting purines into hypoxanthine, which is then converted to xanthine, and then finally to uric acid. The breakdown is performed by the enzyme xanthine oxidase. The process happens in the liver and contributes roughly to 80% of the body's uric acid. Uric acid is a molecule that can be filtered out of the blood and is excreted in the urine. It has limited solubility in the body fluid. So when there's overproduction or underexcretion of uric acid, hyperuricemia happens. The uric acid can precipitate in the synovial joints and form urate crystals, which can elicit an immune response, bringing about inflammation and pain. This is why the joints become red, hot, swollen within hours, causing gouty attack. Over time, repeated gouty attacks can lead to the destruction of joint tissue, to a bulged, deformed joint, a condition which we know as gouty arthritis. Uric acid can also precipitate in the kidney tubules, and chronic gout can lead to tophi formation. The symptoms of gout includes intense pain, stiffness, tenderness, then there's discoloration or redness, warmth, and swelling due to the body's inflammatory response to urate crystals. The cause of gout is the buildup of excessive uric acid in the body. And gouty arthritis can be triggered by various factors, which includes lifestyle and dietary causes such as alcohol consumption, consuming sugary drinks, sweets, and high fructose syrup. Also, the increased consumption of purine-rich foods such as organ meats, game meats, red meat, certain seafood, turkey, gravy, and meat sauces. Genetics is also another factor that can trigger gout. Family history can play a role in predisposing individuals to gout. As gout is partly genetic, you are more likely to experience gout if you have a biological parent or grandparent who has gout. There are certain medical conditions that can increase the risk of gout. This includes overweight or obesity, metabolic syndrome, which is a group of conditions that include high blood pressure, high blood sugar or diabetes, abnormal cholesterol levels, and excess body fat around the waist. Also, chronic kidney disease, a condition where the kidneys are damaged and cannot filter blood the way they should and may be unable to excrete uric acid. Conditions that cause cells to turn over rapidly, such as psoriasis, hemolytic anemia, or some cancer, and cancer treatments like chemotherapy and radiation. Also, Keeler-Miller syndrome or Lesch-Nyhan syndrome, two rare conditions in which the body either does not have the enzyme that regulates urate levels or does not have enough of that enzyme. There are also some medication which can raise uric acid levels and contribute to gout, which includes thiazide diuretics, low-dose aspirin, niacin, and cyclosporine. So, improperly treating gout can cause the disease to become more progressive. Over time, gout can begin to affect more joints throughout the body and cause problems like gout tophi and permanent damage. What are the stages of gout progression? Stage 1. High uric acid levels. It's also called asymptomatic hyperuricemia. There is no painful, red, or swollen joints, but just an elevated uric acid in blood tests. Though high uric acid isn't enough to diagnose gout, as many people with hyperuricemia never develop clinical gout. Stage 2 or the acute gout. This is the stage when there is sudden, unexpected nighttime attack of gout symptoms. There's pain, redness, and swelling due to the inflammatory reaction to the urate crystals released into the joints. Stage 3 or the intercritical gout, it is the period of remissions between gout attacks. Intercritical gout is the in-between stage where a person has already had a gout flare but is presently not having any joint pain or swelling. The last stage, or stage 4, is the chronic gout, which usually takes many years of uncontrolled gout to get to this stage. This stage is also called the tophaceous gout because of the uric acid deposits which form nodules called tophi. This is the stage where a person can have some joint pain from gout just about all the time. Individuals with chronic gout has an increased risk of developing kidney stones and urate nephropathy in which urate crystals deposit in the interstitium of the kidney. In summary of what we have discussed so far, gout is an inflammatory disease which typically affects the first metatarsal joint. Uric acid precipitates and forms urate crystal that deposits into the joints, causing inflammation and pain. Some conditions that lead to hyperuricemia and gout includes overproduction of uric acid, overconsumption of purines, lack of uric acid excretion, cancer treatments such as chemotherapy and radiation, and some conditions like diabetes and obesity. Gout is one of the most controllable forms of arthritis. It is made possible by early diagnosis, treatment, and lifestyle changes, which will be discussed to you by Ma'am Carol. Thank you.
Hello everyone, good day. On behalf of my team, Qatar UAE Group, I would like to introduce myself. I am Carolina Obaldo, presently working as a nurse supervisor here in the United Arab Emirates for 17 years now. I will be discussing three topics in relation to gout. The first topic is that what about the diagnostic tests to be utilized? The second topic is what about the medications to be given for our patients during a gouty attacks? And lastly is what about the nursing responsibilities that we will be implementing in relation to gouty attacks? Now, let us go on the first slide that I have. We have several tests to be done for a patient such as joint fluid analysis, synovial biopsy, ESR test, serum uric acid test, CBC test, CRP test, and imaging test. So with this, it will help us determine the extent of the condition of our patients. I will not be discussing it anymore due to time constraints. So in general, these are the diagnostic tests to be utilized for our patients. The next slide is this is the summary that I've done in relation to the medication management for our patients. So with this, we have to think of what would be our objective in dealing with gouty patients, or those patients who had a gouty attack. So the first objective that I have is that to treat the pain and inflammation. And the second is how are we going to lower the uric acid concentration in the body. Let us go first on the first objective, which is to treat pain and inflammation. So to treat pain and inflammation, the first drug of choice is NSAID. NSAID is, what is the action? So once the patient ingested or taken the NSAID, then there will be prostaglandin inhibition of the prostaglandin synthesis. So what is prostaglandin? Prostaglandins are group of lipids that are made at the sites of the damaged tissue. So if the action of the prostaglandin will be inhibited after the ingestion of NSAID, then there will be no prostaglandin formation on the site, so which means there will be no pain and there will be no inflammation. The next medication in line is colcinin. So what does it do in the body? Once ingested by our patients, there will be inhibits the activity of the phagocytes. So as well as it inhibits leukocyte migration to the joints, and it inhibits phagocytosis. With all of these pharmacodynamics that are made by colcinin once taken by our patient, there will be no phagocytes, and there will be no pain, and there will be no inflammation on that area. This is useful during the first 48 hours of a gouty attacks. Now, let us go on the next objective that we have. What about how are we going to lower the uric acid concentration in the body? So it is divided into two category or classification. This is about the medications to be utilized. The first classification is the hyperuricemic, and the other one is uricosuric. Now, what are the types of hyperuricemic medicines? There are two types that are on my list, which is allopurinol and febuxostat. So what does it do in the body once ingested? So the main action or pharmacodynamics is that it inhibits the xanthine oxidase. And what about this xanthine oxidase? Xanthine oxidase is an enzyme that synthesizes the uric acid from hypoxanthine. Hypoxanthine is a purine derivative. So if allopurinol and febuxostat was ingested or taken by our patients, then there will be prevention of the uric acid formation as well. This is the main action of that medication for our patients. Let us go now on the next medication, which is the uricosuric type of medicines. So there are also two types that I will be giving, which is the probenecid and sulfenpyrazone. What does it do again once ingested by our patient? It acts to inhibit the urate reabsorption to the kidney, and it also pro-compete from the urate transporter, which it penetrates the bloodstream and it will be excreted in the urine. So in general, these are the pharmacodynamics of this uricosuric type of medicine, which is the probenecid and sulfenpyrazone. Let us go into details about these medications. NSAID. What is NSAID? NSAIDs are divided into groups based on chemical structure and selectivity. We can say that it is divided into acetylated salicylates, example is aspirin. Non-acetylated salicylates, example is diflunisal and salsalate. Third one is propionic acid, examples are naproxen, ibuprofen, acetic acid such as diclofenac, indomethacin, and tolmethine. The fourth one is enoloic acid. Examples are meloxicam and piroxicam. And the fifth type or group of NSAID is antranilic acid. Examples are mefenamic acid and meclofenamates. The next slide is what about the indications of these NSAIDs? NSAID reduce swelling and with immediate effect. Again, I mentioned earlier already on the first slide that inhibits the prostaglandin synthesis and it inhibits urate crystal phagocytosis as well. I have one note here to keep in mind. Aspirin is not used during a gouty attacks because it causes renal retention of uric acid at a low dose. Caution as well, aspirin, salicylates, and tolmethine should not be given for our patients. The next medicine, as per the diagram that I made, is the colcinin. Colcinin is absorbed readily after oral administration. The peak time is within 2 hours and eliminated with serum half-life of 9 hours. What are the pharmacodynamics? I mentioned it already earlier that it inhibits leukocyte migration, it inhibits phagocytosis, it inhibits formation of leukotriene B4 and 1L1B as well. The indication is used between attacks. It prevents attacks of acute Mediterranean fever. It also there's a mild effect in sarcoid arthritis and hepatic cirrhosis. And it also treats and prevents pericarditis, pleurisy, and coronary artery disease as well. The dose would be 0.6 milligram for 1 to 3 times a day. And for terminating a gouty attack, it should be 1.2 milligrams followed by 0.6 milligram oral dose. The next is what are the adverse effects of this medicine? There will be diarrhea, nausea and vomiting, abdominal pain, hepatic necrosis, acute renal failure, disseminated intravascular DIC, seizures, hair loss, bone marrow depression, peripheral neuritis, myopathy, and in some cases, death. Indomethacin, replacement of colcinin, it will lower down WBC and platelet. Uricosuric acid. I made a diagram. The examples are probenecid, sulfenpyrazole, and lesinurad, which is currently in phase 3 trial already. Pharmacokinetics is probenecid is reabsorbed by the renal tubule, metabolized slowly with half-life of 5 to 8 hours. And for the sulfenpyrazole, its hydroxylated derivatives is secreted in the kidneys. Give once or twice a day. Again, the pharmacodynamics of these medicines is to inhibit the active transport sites for reabsorption and secretion in the proximal renal tubule. Thus, it decreases in the reabsorption of the uric acid in the body. Again, the indication for gouty patient with under-excretion of uric acid, allopurinol and febuxostat is contraindicated, and if the tophi is already present. Next is what about the adverse effect? There will be GI irritation, nephrotic syndrome, rarely aplastic anemia. There should be increased fluid intake in relation to this type of medicine so that we can prevent stone formation. The dose of the probenecid is 0.5 grams daily in divided dose, and for the sulfenpyrazole, it is 200 milligrams daily. Hyperuricemic type of medicine. This is allopurinol, febuxostat, and peglotiase. Allopurinol, 80% absorbed after oral administration, and the terminal serum life is 1 to 2 hours. Again, the pharmacodynamics is reduces the total uric acid in the body by inhibiting the xanthine oxidase. Next is febuxostat. Pharmacokinetics, 80% absorbed following oral administration. Maximum concentration approximately 1 hour and half-life of 4 to 18 hours. Dosing on once daily, which is 40 to 80 milligrams. About the pharmacodynamics, it is a potent and selective inhibitor of xanthine oxidase and more effective than allopurinol. And the adverse effect, there will be diarrhea, headache, and nausea for this type of medicine. The next medicine is peglotiase. Pharmacokinetics is 8 milligrams IV every 2 weeks IV infusion. Rapid acting peak decline of within 24 to 72 hours. And serum half-life of 6 to 14 days. And peglotiase decayes, converts uric acid to allantoin. It is highly soluble, easily eliminated in the kidney. Should not be used for asymptomatic hyperuricemia. And the adverse effect of peglotics is gout flare, immune response, less, anaphylaxis, nephrolithiasis, arthralgia, muscle spasm, anemia, nausea, and vomiting, upper respiratory infection, peripheral edema, UTI, diarrhea, and we have to be cautious to use it with G6PD type of patients. And the last medicine, not the last, actually is the glucocorticoids. Glucocorticoids is the treatment of severe symptomatic gout given intra-articular, systemic, or sub-Q routes. One of the best example is prednisone, which is to be given at 30 to 50 milligrams for 1 to 2 days, and it should be tapered over 7 to 10 days. The next medicine or example of glucocorticoids is triamcinolone. It is given intra-articular, and it can be given 10 milligrams in small joints, 30 milligrams on the wrist and ankle and elbow, and it can be given 40 milligrams for the knee. The side effect of these glucocorticoids is mood change and increased blood sugar and elevates the blood pressure. The last medicine to be keep in mind is the interleukin-1 inhibitor. So this drug is targeting the 1L1 pathway, and canakinumab, this is a fully human anti-1B monoclonal antibody which provide rapid and sustained pain relief, and the dose is 150 milligrams subcutaneous. So this medicine prevent gout flares while urate lowering therapy as well. So I discussed already all the medications that are utilized for the gout, and the next topic would be in relation to nursing responsibilities. In nursing roles and responsibilities, we have to make a nursing care plan for our patient. By doing so, we have to make sure that to identify the subjective and objective cues of our patients. So for the subjective cues, we have sudden pain in joints, often in the big toe, stiffness in the joint, tenderness of the joint, limited ROM, and itching. And for the objective, we have tophi nodules on the skin, we have renal calculi, joint inflammation, joint edema, and erythema. With all of these signs and symptoms, we will be able to make our nursing care plan for our patients. The first is assess pain, assess and manage the pain. How are we going to do that? So we can assess and manage the pain by administering pain management as needed. So administering pain management as needed. First thing is assess and manage the pain. In order for us to do that, we have to administer medication as ordered. We have to apply cool clothes as tolerable. We have also to assist the patient with positioning to avoid pressure on the affected joints. And during the acute attack, it can cause intense pain for the first 36 hours. So we have to make sure that we offer all of this non-dependent role for our patients in order for our patients to be more comfortable. Next is check the patient's allergy status. So this is again rule of the thumb in order for us to not administer any type of medication which is not suitable for our patient. And the next is what about we have to assess as well if the patient is pregnant. Another rule of the thumb in relation to medication management. So next is assess laboratory and diagnostic studies. I mentioned and I discussed it earlier already. Assist with mobility. Due to pain and inflammation, patients may require assistance with mobility for safe ambulation and transfer. Monitor signs and symptoms of joint inflammation. Also, elevate the limb. Elevating the limb is also one important thing for us to prevent inflammation. Promotes hydration, increase fluid intake. So this prevents dehydration and helps the kidney excrete the uric acid. Assist with active and passive range of motion exercises. So with this one, we can prevent, of course, these contractures or okay. Assist with active and passive range of motion exercises. This prevents any joint stiffness and increased mobility for our patient. Nutritional education is very important. Adjust lifestyle behavior. Gouty attacks can be minimized by reducing risk factors such as intake of alcohol, beverages, sugary drinks, and high purine foods such as red meats and some seafood for that matter. The next nursing responsibilities is ask the patient for any medical or family history of hemophilia, GI ulcers, or bleeding disorders. This is to prevent any further complications in relation to these patients. For some of the medications to be taken can cause GI bleeding or bleeding tendencies for that matter. The next is check the patient's serum blood sugar level if taking anti-diabetic alongside with NSAID, because if these two medications are taken together, then there's a possibility to lower down the blood sugar level of our patient. Provides emotional support and counseling to patients experiencing anxiety or frustration related to gout management and its impact on daily life. Next is assist patient in finding comfortable sleeping positions during gout attacks to improve sleep quality. Monitor renal function regularly, especially in patients with a history of kidney disease or those on urate-lowering medications. Collaborate with physicians, dietitians, physical therapists, and other healthcare professionals to develop a comprehensive care plan for patients with gout. Patient education on complications and follow-up care is very important. So that ends my report. So the next report will be done by my colleague or by my team, which is from Qatar. Thank you so much.
Hello, good morning everyone. I will be the one assigned discussing to you about rheumatoid arthritis. As you can see in this photo, it is obvious the differentiation of the normal hand and the one with rheumatoid arthritis. Now, let me ask you, do you know someone who is having rheumatoid arthritis? Okay, thank you for that answer. I myself can relate on that because my mom itself has an rheumatoid arthritis. So this one, as you can see in the photo, look at their hands. It's so much inflamed. Okay, I will discuss to you more about the RA on the following slide. As we all know, rheumatoid arthritis is an autoimmune disease, which means the body's immune system attacks its own healthy cells. The cause is unknown, but there are several risk factors to consider. Number one is age, which begins in middle age, 30 to 40 years old. Women are more likely to develop RA than men, family history, cigarette smoking, and overweight. With regards to the pathophysiology, this foreign antigen will be the risk factors. In case of RA, CD4 cells initiated will set in motion in immune response altogether, such as activations of B and T cells, activation of macrophages, and activation of endothelial cells. As you all know, CD4 cells are pivotal in playing central role in immune response. It fights infections and it serves as critical defense structures of immune system. The B cells make protein called antibodies to fight pathogen. The T cells are the type of white blood cells called lymphocytes. It protects you by destroying the harmful pathogens and by sending signals that help control your immune system response. Regarding the monocyte activation, it is classified as classical monocyte and intermediate, which is M1 macrophages, which trigger cytokine, TNF factor, interleukin-1, which function as pro-inflammatory response, resulting bone erosion and inflammation. Non-classical monocytes, on the other hand, which is the M2 macrophages, only function as anti-inflammatory response, results to phagocytosis and resolution of inflammation. Along with the inflammation process is the activation of endothelial cells, which are the key regulators of inflammatory response in rheumatoid arthritis. Endothelial cells in the synovium play a central role in the pathophysiology. The cells achieve in several ways. First, it is a component of blood vessels in the subintima endothelial cells, allow migration of leukocytes such as B cells, T cells, monocytes, neutrophils, and dendritic cells into the joint tissue and fluid. Endothelial cells undergo activation, expressing adhesion molecules and pressing chemokines leading to leukocytes migration from blood into the tissue. Second is the permeability of endothelial cells, which increases, leading to plasma extravasation, to edema formation, and to swelling of the joints. Third, the endothelial cells proliferate as a part of androgenic process of the growing panus. Panus is the lining of the joints which is become inflamed in RA. That's it. Regarding the sign and symptoms of rheumatoid arthritis are the following: tender, warm, swollen joints, joint stiffness that is usually worse in the morning and after inactivity or at rest. Regarding the finger, there is one neck or boutonniere deformity as you can see in the photo, fatigue, fever, and loss of appetite. Regarding the diagnostic test, they are getting the family history, physical exam, laboratory tests such as rheumatoid factor, ESR or erythrocyte sedimentation rate, CRP, and also images such as chest X-ray. And now let's discuss the pharmacologic treatment. With regards with the pharmacologic treatments, the most common is the use of DMARDs or disease-modifying anti-rheumatic drugs. They said they decrease inflammation, improve symptoms, and slow the bone damage associated with rheumatoid arthritis. They affect more basic inflammatory mechanism than do glucocorticoids and the NSAIDs do. The types of DMARDs are the following: conventional synthetic DMARDs, targeted synthetic DMARDs, and biological DMARDs. I will discuss further more of them in the next slides. Now let's discuss the conventional synthetic DMARDs. Number one will be methotrexate. It is indicated as first-line synthetic DMARD for treating rheumatoid arthritis, and it's used mainly to 50 to 70%. It decreases the rate of new erosion. It decreases inflammation, which suppresses function of macrophages and neutrophils. It has direct inhibitory effects in proliferation and stimulate apoptosis in immune inflammatory cells. Additionally, it inhibits pro-inflammatory cytokines linked to rheumatoid synovitis. Its adverse effects are nausea, mucosal ulcers, which are most commonly in toxicities, GL ulcerations, and alopecia. Regarding its pharmacokinetics, it is administered either orally or parenterally. 70% are absorbed after oral administration, and its serum half-life is usually only to 6 to 9 hours. It is excreted principally in the urine, but up to 30% may be excreted in the bile. Its drug interaction is hydrochloroquine can reduce the clearance or increase the tubular absorption of methotrexate. It is contraindicated in pregnancy as it might cause birth defect. It can be combined safely with other DMARDs such as abatacept, rituximab, anakinra, and tocilizumab. Number two will be azathioprine. Its indication is in the management of active rheumatoid arthritis and prevention of kidney transplant rejection. Its mechanism of action is it suppresses the blood cell that cause inflammation. Its adverse effects is bone marrow suppression, GI disturbances, increased infection risk. Rarely there are fever, rash, and hepatotoxicity, which signals acute allergic reaction. It's pharmacokinetic. It can be given orally and parenterally. Number three will be chloroquine and hydrochloroquine. Its indication, it is anti-malarial, but they are approved for RA, but they are not considered as very effective DMARDs. Its mechanism of action, it suppresses the blood cells that cause inflammation. It inhibits the DNA and RNA synthesis and by trapping the free radicals. Its adverse effects are ocular toxicity, dyspepsia, nausea and vomiting, abdominal pain, and rashes. Its pharmacokinetics, it's rapidly absorbed and 50% are protein-bound in the plasma. Drugs are deaminated in the liver and have blood elimination half-lives up to 45 days. Number four will be cyclophosphamide. Its indication, it is used regularly at 2 mg per kilogram per day to treat SLE, vasculitis, Wegener's granulomatosis, and other severe rheumatic disease. Its mechanism of action, it is major active metabolite in phosphoramide mustard, which cross-link DNA to prevent cell replication. Its T-cell suppression correlate with clinical response in the rheumatic disease. Its adverse effects are nausea and vomiting and diarrhea. Regarding its pharmacokinetics, it can be administered via oral or intravenous route with equal clinical efficacy. Number five will be cyclophosphamide. Its indication, it is approved use for RA and retards the appearance of new bony erosions. Its usual dosage is 3 to 5 mg per kilogram per day divided into 2 doses. Its mechanism of action, it is peptide antibiotic but is considered a synthetic DMARD. Its adverse effects are leukopenia, thrombocytopenia, anemia, and high doses can be cardiotoxic or neurotoxic. Cyclosporin pharmacokinetics, its absorption is incomplete and somewhat erratic, although a microemulsion formulation improves its consistency and provides 20 to 30% bioavailability. Grapefruit increases cyclosporin bioavailability. Number 6 is leflunomide. Its indication, it is effective as methotrexate in RA, including inhibition of bone damage. Its mechanism of action, it undergoes rapid conversion both in the intestine and in the plasma to its active metabolite. It inhibits also T cell proliferation and reduces production of autoantibodies by B cells. Its adverse effects are diarrhea, mild alopecia, weight gain, and sometimes increased blood pressure. Its pharmacokinetics, it's completely absorbed from the GUT. It has mean plasma life of 19 days. Number 7 is mycophenolate mofetil. Its indication, it is usually used as dosage of 2 grams per day to treat RA. There are no well-controlled data regarding its efficacy to this disease. As synthetic DMARD, it is converted to mycophenolic acid, the active form of the drug. The active product inhibits inosine monophosphate dehydrogenase, leading to the suppression of T and B cell proliferation. Its adverse effects are nausea, dyspepsia, abdominal pain, and hepatotoxicity. The last synthetic DMARD will be sulfasalazine. It is effective in RA and reduces radiologic disease progression. Its mechanism of action is it's metabolized to sulfapyridine and 5-aminosalicylic acid. Sulfapyridine is probably the active moiety when treating RA. Its adverse effects are nausea and vomiting, rash, and headache. Its pharmacokinetics, only 10 to 20% orally administered sulfasalazine is absorbed. Sulfasalazine is excreted unchanged in the urine, and sulfapyridine is excreted after hepatic acetylation. Sulfasalazine's half-life is 6 to 17 hours. Regarding tofacitinib, it is marketed as biologic but it is actually as targeted synthetic DMARDs. Its indication, it is originally developed to prevent organ allograft rejection. In the US, it is approved for the treatment of adult patients for moderately and severe active RA who have failed or intolerant to methotrexate. Its mechanism of action, a targeted synthetic small molecule that selectively inhibits all members of the Janus kinase. In RA patient receiving tofacitinib, it rapidly decreased the CRP. Its adverse effects, it increases the risk of infection. Upper respiratory tract infection and urinary tract infection represent the most common infection. Its pharmacokinetics, it is recommended dose of tofacitinib in the treatment of RA as 5 mg twice daily, and it should not be given to patients with severe hepatic disease. Now, let's go to biologic DMARDs. Number 1 will be abatacept. Its indication, it can be used as monotherapy or in combination with methotrexate or other DMARDs in patients with moderate to severe RA. Its mechanism of action, it is a co-stimulation modulator that inhibits activation of T cells. Its adverse effects, it increases risk of infection and predominantly of the upper respiratory tract infection. Its pharmacokinetics, its recommended dose of abatacept for the treatment of adult patients with RA is 3 intravenous infusions, which are day 0, week 2, and week 4, then followed by week monthly infusion. Dose is based on the body weight. And also, it's available as subcutaneous formulation and is given subcutaneously once weekly. Its drug interaction, patients should be screened for latent tuberculosis or viral hepatitis before starting the medication. Live vaccine should be avoided in patients receiving abatacept and up to 3 months after discontinuation of the medication. Number 2 is rituximab. Its indication, it is indicated for the treatment of moderately to severe active RA in combination also with methotrexate. Its mechanism of action, it is a chimeric monoclonal antibody biologic agent that targets CD20 B lymphocytes. It rapidly depleted peripheral B cells, although this depletion correlates neither with efficacy nor with toxicity. Its adverse effects are only rash. Pharmacokinetics, it is given as 2 intravenous infusion of 1000 mg separated by 2 weeks, and it may be repeated 6 to 9 months as needed. Number 3 will be tocilizumab. It is indicated for adult patients with moderate to severely active RA who have had an inadequate response to one or more DMARDs. Its mechanism of action, it is humanized monoclonal antibody targeted against interleukin-6 causing immunosuppression. Its adverse effects are serious infection including tuberculosis, fungal, viral, and other opportunistic infections, sometimes headache, hypertension, and even elevated liver enzymes. Its pharmacokinetics, the half-life of tocilizumab are dose-dependent, approximately 11 days for the 4 mg per kilogram per dose and 13 days for 8 mg per kilogram per dose. Now, let's proceed to interleukin-1 inhibitors, which are anakinra, canakinumab, and rilonacept. The pharmacokinetics of those drugs are all of them are given subcutaneously. Anakinra, it reaches a maximum plasma concentration after 3 to 7 hours and has a 4 to 6 hours terminal half-life, while canakinumab has a peak serum concentration of 7 days after a single subcutaneous dose injection and has a 26 days mean terminal half-life, while rilonacept has a steady-state plasma concentration reached after 6 weeks. Their mechanism of action also differs. In anakinra, it is the oldest drug in this family but is now rarely used in RA. Canakinumab, on the other hand, is a human IgG1 monoclonal antibody against interleukin-1 beta. Rilonacept is a legal binding domain on the interleukin-1 receptor which neutralizes interleukin-1 beta and prevents its attachment to interleukin-1 receptors. Their adverse effects is the injection site reaction, which are commonly 40%, and upper respiratory tract infection. Now, let's proceed with the TNF blocking agent or tumor necrosis factor blocking agent. Number 1 will be adalimumab. Its mechanism of action, it is a fully human IgG1 anti-TNF monoclonal antibody. Its pharmacokinetics, it is given subcutaneously and has a half-life of 10 to 20 days. The usual dose in RA is 40 mg every week, and the dosing is frequently increased to 40 mg weekly. It is indicated to decrease the rate of formation of new erosion. It is effective both as monotherapy and combination of methotrexate and other synthetic DMARDs. Number 2 will be certolizumab. It is a recombinant humanized antibody Fab fragment conjugated to a polyethylene glycol with specific to human TNF. It is given subcutaneously and has a half-life of 14 days. It is indicated for the treatment of adults with moderately to severe active RA. It can be used as monotherapy or combination with non-biologic DMARDs. Number 3 is etanercept. Its mechanism of action, it is a recombinant fusion protein consisting of two soluble TNF receptor moieties linked to the Fc portion of the human IgG1. It is given subcutaneously as 25 mg twice weekly or 50 mg weekly. This drug is slowly absorbed with the peak concentration of 72 hours after drug administration. Its serum half-life is 4.5 days. It is approved treatment for rheumatoid arthritis and can be used as monotherapy, although 70% who are taking this medication are also using methotrexate. Number 4 is golimumab. Its mechanism of action, it is a human monoclonal antibody with high affinity for soluble and membrane-bound TNF. Golimumab effectively neutralizes the inflammatory effects produced by a TNF-alpha seen in disease such as rheumatic arthritis. It is administered subcutaneously and has a half-life approximately of 14 days. Golimumab with methotrexate is indicated for rheumatoid arthritis. It is used for treatment of moderately to severely active rheumatoid arthritis. Number 5 is infliximab. Its mechanism of action, it is a chimeric IgG1 monoclonal antibody that binds with high affinity to soluble and possibly membrane-bound TNF-alpha. Its mechanism of action is same as adalimumab. It is given as intravenous injection with induction at 0, 2, and 6 weeks and maintenance every 8 weeks thereafter. Its terminal half-life is 9 to 12 days without accumulation, and repeated dosing is recommended with interval of 8 weeks. It is indicated for RA with a combination of methotrexate to decrease the rate of the new erosion formation. The adverse effect of TNF blocking agents are the following: risk for bacterial infection and macrophage-dependent infection including tuberculosis, fungal, and other opportunistic infection, increased risk of HPV reactivation, increased risk of skin cancer including melanoma, which necessitates periodic skin examination, especially in high-risk patients. Now, let's proceed with the nursing responsibility for patients with arthritis. Number one will be managing pain and discomfort through appropriate pain management intervention and strategies, promoting joint mobility and preventing deformities through range of motion exercises, joint protection techniques, and assistive devices, providing education on self-care strategies including medication adherence, joint protection, and energy conservation techniques. With regards with the lifestyle and home remedies, you can do the following. Exercise regularly. Gentle exercise can help strengthen the muscle around your joints and it can help reduce the fatigue you are feeling. Avoid exercising the severely inflamed joints. Apply heat or cold. Heat can help to ease the pain and relax the tense, painful muscle. Cold may dull the sensation of pain and can reduce swelling. And also relax. Find the ways to cope with the pain by reducing stress like guided imagery, breathing exercise, and muscle relaxation. And that will be all for rheumatoid arthritis.
Good day, Dr. My name is Lloyd, and I'm going to present about osteoarthritis. So, what is osteoarthritis? Osteoarthritis is the most common form of arthritis. Some people call it degenerative joint disease or the wear and tear arthritis. It occurs most frequently in the hands, hips, and knees. Osteoarthritis is a complex, a multifactorial degenerative joint disease characterized by the gradual breakdown of joint cartilage, as well as changes in the surrounding bone and soft tissues. Osteoarthritis affects each person differently. For some people, osteoarthritis is relatively mild and does not affect day to day activities. But for others, it causes significant pain and disability. Joint damage usually develops gradually over years, although it could worsen quickly in some people. So, what are the risk factors of osteoarthritis? Anyone can get osteoarthritis, however, it is more common as people age. Women are more likely to develop osteoarthritis than men, especially after the age of 50. For many women, it develops after menopause. Risk factors also include obesity. Extra weight puts more stress on joints, particularly weight-bearing joints like the hips and knees. This stress increases the risk of osteoarthritis in that joint. Obesity may also have metabolic effect that increases the risk of osteoarthritis. Younger people can also develop osteoarthritis, usually as a result of joint injury and overuse. Knee bending and repetitive stress on the joint can damage the joint and increase the risk of osteoarthritis in that joint. Next is genetics. People who have family members of osteoarthritis are more likely to develop osteoarthritis. Some Asian populations have lower rates of osteoarthritis. 78% of individuals with osteoarthritis are non-Hispanic whites. However, within their own race or ethnic groups, non-Hispanic black and Hispanic populations have higher rates of osteoarthritis than non-Hispanic whites. So what actually happens with osteoarthritis? Researchers do not know what triggers or starts the breakdown of the tissues in the joint. However, as osteoarthritis begins to develop, it can damage all the areas of the joint, including the cartilage. This is the tissue that covers the end where the two bones meet to form a joint. It also causes damage in the tendon and ligaments, the synovium, the lining of the joint, the bone, and the meniscus of the knee. The first picture shows an image of normal cartilage and the one with osteoarthritis. There are actually four types of osteoarthritis. We have the type 1 or the normal, where there is minimal disruption on the joint space. The patient may have little pain. Type 2, where joint space starts to narrow, and there is appearance of osteocytes. Patient may have mild pain, usually relieved by rest. For the type 3, there is a moderate joint space reduction. There is inflammation occurring, and the patient has moderate pain which needs painkillers. Type 4 is a severe type, where joint space is greatly reduced. There are increase in osteocytes and cartilage breaking down is visible. This is where the patients are unable to move due to severe pain. The exact pathophysiology of osteoarthritis is not fully understood, but it is thought to involve a combination of genetic, mechanical, biochemical, and inflammatory factors. Genetic factors include family history of osteoarthritis. There is a genetic component to osteoarthritis, and certain gene variants may predispose individuals to the disease. For example, the cartilage link protein and the collagen. Mechanical stress factors such as joint malalignment, previous joint injuries, overuse of the joints can increase the risk of osteoarthritis in non-specific joints. Systemic factors such as obesity and diabetes can contribute to the development and progression of osteoarthritis. Old age and menopausal women are also included in this factor. With the combination of these factors, it will create a mechanical stress to the joints. Osteoarthritis often begins with excessive mechanical stress on a joint. This stress can result from factors such as joint overuse, injury, obesity, and structural abnormalities. Due to stress, chondrocyte dysfunction develops. Chondrocytes are the specialized cells responsible for maintaining and repairing joint cartilage. Mechanical stress can disrupt the balance between anabolic and catabolic process of chondrocytes. Over time, chondrocytes may become dysfunctional and unable to produce a sufficient extracellular matrix, leading to cartilage damage. With the disruption of chondrocytes, changes in the cartilage occur. The extracellular matrix of the cartilage is composed of collagen and proteoglycans, providing a tensile strength and resistance to compression. In osteoarthritis, there is a loss of proteoglycans and collagen disruption, causing cartilage to become less resilient and more susceptible to damage. With the disruption of the extracellular matrix, synovial inflammation develops. Inflammatory mediators such as cytokines, chemokines, adipokines, neuropeptides are released into the synovial fluid, leading to synovial inflammation. These inflammatory molecules can further damage the cartilage. Continuous inflammation causes subchondral bone changes. Subchondral bone is the bone beneath the cartilage, which undergoes structural changes during osteoarthritis. It may become denser, or what we call the sclerosis, or develop cysts. Microfractures in the subchondral bone can expose the cartilage to inflammatory factors and contribute to joint pain. With the occurrence of these changes in the cartilage, osteophytes start to form. Osteophytes are also known as the bone spurs, can develop at the joint's margins as a response to the loss of cartilage. These bony outgrowths can impede joint movement and causes pain. Due to the occurrence of osteophytes, it could cause changes in the joint mechanics. As cartilage deteriorates and joint structure changes, there is often a noticeable alteration in joint mechanics. This can lead to further stress to the joint, creating a vicious cycle of cartilage damage. There is no single test for osteoarthritis. Diagnosing the condition may include the following: providing to a doctor a medical history that includes your symptoms, any other medical problems you and your close family members have, and any medications you are taking. Having a physical exam to check your general health, reflexes, and joint problems. Having images taken on your joint using the x-rays, which can show loss of joint space, bone damage, bone remodeling, and bone spurs. Early joint damage does not usually appear in x-rays. MRI is also needed, which can show damage to the soft tissues in and around the joint. Generally, MRI helps healthcare providers evaluate a joint that is locking or giving out. Having blood tests to rule out other causes for symptoms. There is no specific blood test that can diagnose osteoarthritis. However, your doctor may order them to rule out other causes of joint pain and inflammation, such as rheumatoid arthritis or gout. Taking joint fluid samples is also needed. Fluid is drawn from the affected joint that can offer clues as to what is happening in that specific joint. Analyzing the joint fluid can help eliminate other possible conditions, such as gout or an infection. So, what are the signs and symptoms of osteoarthritis? The symptoms of osteoarthritis often begin slowly and usually begin with one or few joints. The common symptoms of osteoarthritis include pain when using the joint, which may improve with rest. For some people, in the later stages of the disease, the pain may be worse at night. Pain can be localized or widespread. Joint stiffness, usually lasting less than 30 minutes, in the morning or after resting for a period of time. Joint changes can limit joint movement and development of bone spurs occur. These are extra bits of bone, which feel like a hard lump and can form around the affected joint. Swelling, which could occur on different joint. Swelling results from the ongoing inflammation and could possibly be an infection. The patient may have loss of flexibility. Your patient may have not able to move his joint through its full range of motion. Feeling that the joint is loose or unstable and grating sensation. Patient might feel a grating sensation when he or she uses the joint, and he or she might hear a popping and cracking sensation. Osteoarthritis symptoms can affect joints differently. For example, in the hands, bony enlargement and shape changes in the finger joints can happen over time. For the knees, when walking or moving, you may hear a grinding or scraping noise. Over time, muscle and ligament weakness can cause the knee to buckle. In the hips, you may feel pain and stiffness in the hip or in the groin, inner thigh, and buttocks. Sometimes, the pain from arthritis in the hip can radiate to the knees. Over time, you may not be able to move your hips as far as you did in the past. In the spine, the patient may feel stiffness and pain in the neck and lower back. As changes in the spine happen, some people develop spinal stenosis, which can lead to other symptoms. As symptoms worsen over time, activities that you could participate in become difficult to do, such as stepping up, getting on or off the toilet, or in and out of the chair, gripping a pan, or walking across the parking lot. The primary goals of treatment for osteoarthritis include reducing pain and other symptoms, improving the joint functions, stopping the disease from progressing, and maintaining a health related quality of life to help prevent disability. There is no cure for osteoarthritis. Doctors usually treat osteoarthritis symptoms with a combination of therapies, which may include the following: increasing physical activity such as exercising, which can reduce joint pain and stiffness and increase flexibility, muscle strength, and endurance. Physical therapy with muscle strengthening exercises, such as range of motion and stretching activities to keep your joints limber. Strengthening exercises performed with weights or exercises bands to strengthen muscle that support joints affected by arthritis. Exercises in the water to help lower the stress on the joints while exercising. Balance and agility exercises to help you maintain daily living skills. Low impact activities that give you a moderate level of activity without putting stress on the joints. This may include walking, cycling, swimming, tai chi, water aerobics, and low impact aerobic class. Managing your weight can help reduce the stress on the joints. In addition, if you are overweight or obese, losing weight can help reduce pain, prevent more injury, and increase mobility in the joints. This can be especially helpful for weight-bearing joints such as your knees and your hips. Medications, including over-the-counter pain relievers and prescription drugs, this will be discussed later on by Ms. Jennifer. Supportive devices such as crutches and canes to help patients with ambulation. If other treatments are not helping and if the joint is damaged extensively, some people may have surgery. When considering surgery, many factors may determine if it is the right option, including your age, pain intensity, the degree to which arthritis interferes with your lifestyle, level of disability, and occupation. Surgeries may include one or more of the following. First, we have the osteotomy or the surgical removal of the piece of a bone. Second, we have the partial or total joint replacement surgery. This is the removal of part of the damaged joint and replacing it with a new joint made up of plastic, a metal, or a ceramic. Other therapies such as massage can increase blood flow and bring warmth to the area. Some research shows that acupuncture may help relieve osteoarthritis pain. Doctors believe that the needles stimulate the release of natural, pain relieving chemicals produced by the nervous system. But before using the therapies, talk to your doctor about the best options for your treatment. So, this is the last part of my presentation. I will give the floor to Ms. Jennifer to discuss the drugs used in osteoarthritis. Thank you and have a nice day, everyone.
Good day, everyone. My name is Jennifer Ogacion. I'm a trauma nurse currently working here in Doha, Qatar. And my part is to discuss about the drugs used in osteoarthritis. The common medications used to alleviate pain caused by osteoarthritis include acetaminophen, NSAIDs, and tramadol. Acetaminophen is also called paracetamol. And why is this so? It is because of its chemical name para-acetaminophenol. Some countries like UK, they use the drug name paracetamol. In some countries like USA, they use the drug name acetaminophen. Acetaminophen is an analgesic and antipyretic drug. Its indication include mild to moderate pain management, and it's relatively safe compared to NSAIDs. According to the study of Anna Pramachandran's acetaminophen hepatotoxicity, a review of seminars in liver disease 2019, acetaminophen is one of the most popular and safe medications worldwide. However, due to its wide availability, it is frequently implicated in intentional and unintentional overdose, where it can cause severe liver injury and even acute liver failure. Therefore, it is always important to remember not to exceed dose of 4 grams per day. Its mechanism of action is not fully elucidated. However, it is widely accepted that the analgesic effect of acetaminophen is mediated through the CNS. Adverse effects of acetaminophen include hepatotoxicity, as I just mentioned earlier. Also, it can cause nausea and vomiting and abdominal pain. And with regular use of acetaminophen, it may cause hypotension and palpitation. For the genitourinary, acetaminophen is associated with significant risk of newly developing renal impairment in adults. And with large doses, it may occur dizziness, excitement, and disorientation. Acetaminophen pharmacokinetics. Upon ingestion, acetaminophen is rapidly absorbed from the GI tract and is quickly distributed throughout the body. It is metabolized in the liver. Peak plasma concentrations are achieved within 30 to 60 minutes. The half-life of acetaminophen is 2 to 3 hours and it's relatively unaffected by renal function. Less than 5% is excreted unchanged, and in large doses, a minor but highly reactive metabolite is important because it is toxic to both liver and the kidney. For drug-to-drug interaction, acetaminophen should not be used together with alcohol and rifampin, a drug used to treat bacterial infection, as these medications may enhance hepatotoxic effect of acetaminophen. Acetaminophen should not be used together with carbamazepine, an anticonvulsant or antiepileptic drug, as carbamazepine increases the metabolism of acetaminophen. Also, acetaminophen should not be used together with vitamin K antagonists like warfarin, because the anticoagulant effect of vitamin K antagonists may enhance by acetaminophen. Additionally, vaccines should not be taken with acetaminophen as it may diminish the therapeutic effect of vaccines. Now let's discuss about NSAIDs or non-steroidal anti-inflammatory drugs. Most commonly used NSAIDs include aspirin, ibuprofen, naproxen, diclofenac, celecoxib, and many more. NSAIDs are used to relieve mild to moderate pain and to reduce swelling. It is mostly prescribed for treating conditions such as arthritis. For the mechanism of action, the cyclooxygenase is required to convert arachidonic acid into thromboxanes, prostaglandins, and prostacyclin. With the use of NSAIDs, it blocks cyclooxygenase enzyme, inhibiting prostaglandins biosynthesis, thereby reduces inflammation and relieves pain. NSAIDs adverse effect. In the CNS, it may cause headache, tinnitus, dizziness. In the cardiovascular, it may cause fluid retention, hypertension, and edema. Gastrointestinal, it may cause abdominal pain, nausea, and vomiting. Hematologic, it may cause rare thrombocytopenia, neutropenia, and aplastic anemia. Hepatic, it may cause abnormal liver function test results and rare liver failure. Pulmonary, it may cause asthma. In the skin, it may cause rashes, pruritus, and in renal, it may cause renal insufficiencies, renal failure, and proteinuria. Now let's discuss about the pharmacokinetics. We have this model LADME. Liberation occurs when the drug is released from the solid dosage form into the GI tract. The NSAIDs are absorbed primarily in the stomach and small intestine. It is highly distributed in the bloodstream and tissues. Many NSAIDs are highly protein bound in the blood, primarily to albumin. This binding can affect the drug's distribution and its ability to reach target tissues like inflamed joints. For the metabolism, NSAIDs are primarily metabolized in the liver and it is excreted via the kidneys, and their excretion can be influenced by factors like renal function. So for the patients with impaired kidney function, the elimination may be slower and it may increase the risk of drug accumulation and potential toxicity. Now for NSAIDs drug interaction, it should not be taken together with warfarin as it increases the risk of bleeding. It should not be taken together with ACE inhibitors as it causes kidney failure when combined. It should not be taken together with diuretics and beta blockers because NSAIDs can oppose the effects of medicines for heart failure and increases blood pressure. It also stops them from working effectively. It should not be taken together with corticosteroids and alcohol as well because NSAIDs can increase the risk of GI ulceration, damage, or bleeding. Our next drug is tramadol. Tramadol is a restricted controlled drug. It is an opioid analgesia and it requires physician's prescription. It is indicated for moderate to severe pain. Tramadol has no significant anti-inflammatory effects. Analgesic effect is by enhancing serotonin release and inhibiting the reuptake of norepinephrine and serotonin, causing inhibitory effect on pain transmission in the spinal cord. Tramadol adverse effects include CNS effects like dizziness, sedated state, drowsiness, and headache. It may also cause constipation, hyponatremia, respiratory depression, seizure, serotonin and withdrawal syndrome. Now let's discuss its pharmacokinetics. After oral administration, tramadol is rapidly absorbed from the GI tract. Its peak concentration for immediate release is approximately 1 to 2 hours. It can cross blood-brain barrier, allowing it to exert its analgesic effects in the CNS. Tramadol undergoes extensive hepatic metabolism primarily in the liver, and its metabolites are mainly excreted through the kidneys. For tramadol drug interaction, tramadol should not be taken together with dopamine antagonists because it may enhance its CNS depressant effect. It should not be taken together with anticholinergic agents because it may enhance the adverse or toxic effect of opioid agonists. It should not be taken together with buspirone and dapoxetine because it may enhance the serotonergic effect of serotonergic agents. Also, it should not be taken together with carbamazepine. Tramadol has also been associated with seizure, as I have mentioned in the adverse effects. So tramadol administration could or counteract anti-seizures effect of carbamazepine. Now it's time for us to talk about the nursing considerations. As a nurse, it is a part of our initial assessment upon admission to properly assess patients' allergies, particularly to the medications that we are giving. And when giving pain medications, we need to do pain assessment and reassessment. It is also important to assess patient's mucous membranes and his or her ability to swallow when giving medications through the mouth. For acetaminophen, liver functions, blood urea, nitrogen, and creatinine levels should be monitored to watch out for hepatotoxicity or renal toxicity. We need also to do CBC monitoring to watch out for hematologic reactions. Toxicity of acetaminophen includes nausea and vomiting, abdominal pain, and elevated bilirubin and liver enzymes. And the antidote for acetaminophen is N-acetylcysteine. For NSAIDs, we need to monitor complete blood count, renal tests, and hepatic panel. We need to watch out for GI bleeding, hypertension, hepatotoxicity, and renal damage. It is recommended to take NSAIDs with meal or with milk to minimize upsetting the stomach and reduce the risk of ulcer. For tramadol, we need to monitor the neurologic aspect of our patients. We need to watch out for seizure and respiratory depression. And most importantly, we need to administer only as prescribed because misuse of tramadol can cause addiction, overdose, or death. So as a nurse, educating our patients and their family is an essential part of our role. As quoted by Maya Angelou, as nurses, we have the opportunity to heal the mind, soul, heart, and body of our patients. They may forget our names, but they will never forget how we made them feel. So we are the Qatar and UAE group, and our presentation ends here. My fellow nurses, let's continue to provide positive impact towards the lives of our patients. Thank you so much for your time. Have a wonderful and blessed day.